All right, let's get into it. Today, we're going to crack the code on body fluid disturbances. This is the kind of high-yield stuff that's not just on your exams, but is absolutely critical in day-to-day clinical practice. So let's dive right in. So, I want to start with a real clinical mystery. Picture this. Your patient is crashing right in front of you. Blood pressure is tanking, heart rate is skyrocketing, but there's no blood anywhere. No obvious reason for it. How is that possible? Keep that question loaded in the back of your mind, because we're going to solve it together by the end of this. Okay, first up, we're opening the case file on a volume crisis. This is what happens when the body is losing a ton of fluid, and fast. It's probably the most straightforward scenario, but you absolutely have to nail it. So here's our guy. He's 25, he's had severe diarrhea for 3 days straight, and now he's tachycardic. His heart is just herring away, and he's hypotensive, meaning his blood pressure is in the tank. His body is waving a giant red flag. So what's the diagnosis? It's hypovolemia. Now this isn't just about being thirsty, it's a serious depletion of the extracellular fluid, the ECF. That's the fluid in your blood vessels and between your cells. The key thing to get right now is that the primary problem isn't the electrolyte mix, it's that the tank itself is running on empty. And that brings us to a golden rule, a huge exam pearl. When a patient is in shock from losing fluid, you have to treat the volume problem first. Forget the osmolality for a minute. Your number one job is to refill that tank with an isotonic fluid. Why? Because without volume, the heart can't pump and organs start to shut down. You can fine-tune the other stuff later. First, you save their life. All right, let's move on to our next case file. Now we're getting into sodium emergencies. You really have to understand sodium because it's the master electrolyte. It's the traffic cop that tells water where to go. And when it's off, things can go wrong fast. So check this out. It's all about one simple principle. Water follows sodium. On the left, with hyponatremia, or low sodium, the blood gets too watery. This forces fluid into the cells, making them swell up like little balloons. On the right, with hypernatremia, high sodium, the blood is super salty, so it yanks water out of the cells, causing them to shrivel up like raisins. As you can imagine, both of these are really, really bad for your brain. Now let's see it in action. Here's our patient, a 60-year-old woman, totally confused, and she's having seizures. Her labs come back, and her serum sodium is 118. That is dangerously low. And her symptoms? That's not random. That is a direct result of her brain cells swelling with all that extra water. Okay, so you know you've got to fix this. The temptation is to just pump her full of sodium, right? But wait, there is a huge catch. What's the main danger if we correct this too aggressively, too fast? This is one of the biggest safety questions in all of medicine. And the answer is osmotic demyelination syndrome. Here's what happens. Her brain cells have kind of gotten used to being swollen in this low sodium world. If you suddenly crank up the sodium outside the cells, you violently rip water out of them. This process is so harsh, it can actually strip the protective myelin coating right off the neurons. It's like stripping the insulation off a wire. The damage is catastrophic and often permanent. And that gives us our next pearl to lock away. When a patient has symptoms from low sodium, especially neurological ones like confusion or seizures, it is an absolute medical emergency. You have to act, but you have to act carefully. Go slow. Okay, for our final case file, we're looking at a totally different kind of problem. This isn't about losing fluid from the body. This is about the fluid being in the wrong place entirely. You've definitely seen this clinical picture before. It's a patient with heart failure. They've got swollen ankles, what we call pitting edema, and when you listen to their lungs, you hear crackles. They're clearly fluid overloaded. But what does that really mean? The mechanism here is edema. Now, what's wild is that their total body water is actually increased, but the pressure inside their tiny blood vessels is so high that it literally forces fluid out of the bloodstream and into the surrounding tissue. It's like a leaky plumbing system. That's what's causing the swelling. So the crucial takeaway here is that edema is not dehydration. It's so easy to get this twisted, but this is a problem of fluid redistribution. They have way too much fluid. It's just not staying where it's supposed to be. And now let's go all the way back to that mystery from the beginning. A patient with acute pancreatitis who suddenly goes into shock. Hypotensive, tachycardic, but no bleeding, no vomiting, no obvious fluid loss. So what in the world is going on? And this right here is the solution to the mystery. Third, spacing. The massive inflammation from pancreatitis has made the patient's blood vessels incredibly leaky. Huge amounts of fluid have poured out of the vascular space and into a third space, like the abdominal cavity, where it does absolutely nothing to support their blood pressure. So even though the total fluid in their body is the same, the fluid in their blood vessels has vanished. To the heart, it's as if they're bleeding out internally. And here it is, the pearl that ties it all together. Third spacing is the hidden cause of shock. The patient is functionally dry inside their blood vessels, which leads to shock, but they haven't lost a single drop of fluid to the outside world. Mystery solved. Okay, so we've cracked all the cases. Now, let's pull it all together and synthesize everything into a clinical cheat sheet, 5 essential rules that will guide you at the bedside. But before we get to the rules, let's do a quick pop quiz to make sure we're straight on the hormones. Which one of these is responsible for only reabsorbing water without messing with sodium? Is it A, aldosterone, B, ANP, or C, ADH? The answer is C, ADH. A really easy way to remember this is that aldosterone saves sodium. ADH, on the other hand, just deals with H2O. It's a pure water hormone. And that distinction is absolutely fundamental to understanding fluid balance. And here it is, your clinical cheat sheet. These 5 rules will seriously help you out. Number 1, sodium controls volume, water controls osmolality, or concentration. Number 2, treat shock first. Always fill the tank with isotonic fluids before you worry about anything else. Number 3, never ever correct sodium too fast. Be methodical, be careful. Number 4, edema is not dehydration. It's a plumbing problem, a fluid redistribution problem. And finally, number 5, third spacing causes hidden hypovolemia. It's the shock you can't see. Commit these to memory, they are pure gold. We have covered a ton of ground here, from simple volume loss to the chaos of sodium, all the way to misplaced fluid. So my final question to you is this. After going through all these cases, which one of these imbalances do you feel the most prepared to spot in a real patient? Thinking about that will really help lock in these concepts. Thanks for sticking with it.